So we'll start with structures of the medulla. We've already covered some of these here. We've colored in dark the white matter tracks. So remember, myelin in white matter stains very dark in a myelin stain, so we've actually got those looking like they would on a regular stain. So in the medulla, very anteriorly, we have our medullary pyramids, and that's going to be containing our corticospinal tract. So they're right in the front there. Just dorsal or posterior to them, we have our medial lemniscus, and that's going to be conveying fine touch, vibration, and proprioception from the contralateral side of the body. And even more posterior, we have our hypoglossal nucleus. So the cranial nerve number 12 nucleus is there, and these are all very close to the midline. And note that cranial nerve 12 is giving off axons. These fascicles are traveling through the brainstem to come out as cranial nerve 12 once they exit the ventral side. Here we can see we've got the shaded in inferior olivary nucleus right there, and we've got several other structures more laterally. So we've got our medial lemniscus here. Over here to the side we have our anterolateral system conveying pain and temperature sensations from the opposite side of the body. Near that, these little dots are going to be our descending sympathetics. They're coming from the hypothalamus, and they're going to be going to the intermedial lateral cell column in the spinal cord. Right here, we've got another nucleus and tract running together. So we have a nucleus here, and its tract will be the axons surrounding it and bringing things to it. This is going to be our spinal trigeminal nucleus and tract. So it's right there. Just a bit medial to it, we've got a weird little structure called the nucleus ambiguus. It's going to be bringing down motor axons, sending them out to cranial nerves 9 and 10 to go to the pharynx, larynx, and palate. And right here, very laterally, we've got this big structure called the middle cerebellar peduncle. Now, depending on where we're at in the medulla, we might have a middle or inferior cerebellar peduncle. So there we've got axons going to the cerebellum. Most posteriorly or dorsally, we've got vestibular nuclei. And last and not least, we have this weird little nucleus surrounding its tract in the middle. This is the solitary nucleus, and its tract on the inside, making that little donut there. And since it conveys taste sensation from the tongue, that's perfectly appropriate. So let's take a look at what's going to happen when the medulla has problems with its blood supply. The majority of the blood to the medulla is coming from the two vertebral arteries, and they also give off an anterior spinal artery. It may be involved here as well. And so these vertebral arteries and the anterior spinal artery are going to give off some paramedian branches that are going close to the midline and going into the substance of the medulla. And you can go back pretty far away, but these paramedian branches will always be close to the midline. In addition to those, we have some short circumflex and long circumflex arteries coming off of the vertebrals and coming around to more lateral structures and going in to take care of all of these guys that are on the inside. And once we see that blood supply, it's a little bit easier to appreciate the problems that can happen. So we'll just get this in on both sides, get our long circumflex branches at least kind of halfway representing themselves here. So if we have ischemia related to one of these vessels, we can wind up with blockage in there, and that will deprive downstream structures of blood. If we have these paramedian branches, or their parent branches here, the vertebral and anterior spinal, if we have them getting clogged or stopped in some way, we can wind up with medial medullary syndrome. And we'll color in on one side, nice and blue for ischemia, lack of oxygen. We're going to lose the medullary pyramid. So we're going to have contralateral spastic paralysis in the body because we're wiping out those corticospinal axons before they decussate. Likewise, medial lemniscus, we're going to lose vibration, proprioception, and fine touch on the contralateral side of the body. And whether we hit cranial nerve 12's nucleus or not, we're going to affect the nerve fascicles that are leaving it. So we're also going to have weakness of that cranial nerve 12 nucleus and nerve, and therefore the side of the tongue ipsilaterally will be weak. And so when the tongue's extended, it will point towards the lesion side because it's pointing towards the weak side. So that's going to be what happens when we have medial medullary syndrome. Over here, we'll follow what happens when we have lateral medullary syndrome. Now, involvement of the inferior olive rarely gets mentioned because it's compensated for by the opposite side, and its functions are a little more sophisticated, and quite frankly, I don't know how they would manifest. But these other structures, when we have a lateral medullary syndrome or a Wallenberg syndrome, make a great deal of sense. We're going to lose our anterolateral system. That's going to cause contralateral loss of pain, temperature on the body. We're going to lose those descending sympathetics. So we're going to have an ipsilateral Horner syndrome on the side of the lesion. We're going to affect that cerebellar peduncle. That's going to cause some ataxia or difficulty coordinating motion. And right here we've got our spinal, trigeminal, nucleus, and tract. That's going to cause an ipsa, and I'm going to say that again, ipsilateral loss of pain and temperature to the face. Contralateral loss of pain and temperature to the body. Ipsilateral loss of pain and temperature to the face. Losing the nucleus ambiguus is going to wipe out our ability to speak clearly. We're going to have a very hoarse voice because our larynx isn't going to work. We might have difficulty swallowing because our pharyngeal muscles and palate are not working properly. And then might lose our solitary nucleus, some viscerosensory problems perhaps, and loss of taste. And something that someone will definitely complain about will be loss of their vestibular nuclei, causing nausea, causing dizziness, vertigo, and possibly nystagmus, since the vestibular nuclei connect up with cranial nerves 6, 4, and 3. Same thing with the Coddle Ponds. We have the blank here without the gray matter indicated, but we'll skip a step to keep our sanity. And here I've got the gray matter, kind of light, and I've got the white matter, again dark because of myelin staining, and we're looking at the Coddle Ponds. So what do we have? Here in the basis of it, we have, just like before, we've got our cortico-spinal and cortico-bulbar tracts carrying upper motor neurons to their targets below. And in case of the body, they're going to be going to contralateral targets. Just posterior or dorsal to that, once again, we have our medial lemniscus. It's scooched a little over laterally, moving off the midline, but it's still relatively medial. Even further posterior, instead of the hypoglossal nerve, because we're in the Coddle Ponds, we have our abducens nucleus, and it's giving off its nerve fascicles here, and they're going to exit the front or anterior ventral side of the brainstem as cranial nerve 6. Now, at this point, we're going to add some new characters to the mix, but before we do, let's go through some of our classic tracts. We've got our anterolateral system still hanging on. It's actually moving a little bit towards the medial lemniscus. They're going to get closer and closer. In close proximity to the ALS, we've got our descending sympathetics from the hypothalamus. And here we've got that spinal trigeminal nucleus and tract. And forgive me, I just realized I didn't color in the tract on this side to indicate that it's myelin. So we'll just let that go. So we've got that here. As usual, our vestibular nuclei are going to be very lateral or dorsal. And here we've got some weird things going on. We've got a lot of Pontine nuclei in the Pontine basis here, and I've actually underrepresented them significantly. So a lot of Pontine nuclei are going to send their axons to the opposite side, and they're actually going to form the middle cerebellar peduncle. So they're going to decussate on both sides. So we have our huge MCP, middle cerebellar peduncle there. A little further posteriorly, near the abducens nucleus, we have the medial longitudinal fasciculus that's allowing the vestibular, abducens, and oculomotor nuclei to communicate with each other. And last, and perhaps most strangely, we have our facial motor nucleus right here. And instead of being sensible and sending its axons straight out, the nerve fascicles from the facial motor nucleus loop around the abducens nucleus and then exit at the pontomedullary juncture, contributing to cranial nerve 7. So these are the major players that we have here in the Coddle Ponds. The major blood supply to the ponds is the great big basilar artery hanging out on its anterior surface. And just like before, we can have branches coming off of it going laterally. So we have short and long circumflex branches. And we can have paramedian branches that are sticking pretty close to the midline. So paramedian branches are there. Lateral circumflex branches of the basilar are heading out here. And there's one in particular that's especially large, and that's going to be the anterior inferior cerebellar artery. So we'll just kind of make this one a little extra beefy on this side. There are other lateral circumflex branches off the basilar, but we're going to make this one especially big, and it's going to be our anterior inferior cerebellar artery, taking care of these more lateral structures out here. So now let's talk about the different problems that can occur. We can once again have problems with the paramedian branches or the more lateral ones, but one thing that distinguishes these pontine lesions from each other is how deeply these structures are affected. There's a lot of variability. So the first thing that can happen is we can have a lesion of the pontine basis, this very ventral part with the corticospinal tract, corticobulbar tract, and the pontine nuclei. If we only really affect the corticospinal tract, we're going to have what's called a pure motor hemiparesis, paralysis of the opposite side of the body because of the corticospinal and upper motor neuron losses. But if we involve enough of these pontine nuclei, we're actually also going to cause ataxia, because that is not going to get to the cerebellum the way it should, and we'll have kind of an ataxic hemiparesis. So paralysis along with ataxia. And that is what can happen if we have a lesion involving the basis here. If the lesion progresses further in, depending on just how deeply we're following these arteries or how deeply that lesion is going to extend, we can have a lesion of the medial pontine basis and tegmentum. And we can involve various structures here. Now there are different syndromes associated with this. Fauville's pontine wrong way eyes, Millard-Gubler syndrome, and others. I do not want you to distinguish them from each other, but I want you to know that they only vary depending on what structures are involved. So if we have a lesion of the pontine basis, we're going to have that same problem, ataxia and contralateral hemiparesis, but we're also likely to involve the dorsal column medial lemniscal system. And we're going to wind up with a contralateral loss of vibration, fine touch, and proprioception information. And we may hit the facial motor nucleus, or we may hit the facial fascicles. If that happens, we're going to wind up having an ipsilateral Bell's palsy or facial palsy, as those motor axons to the muscles of the face are no longer going to be getting there. And we're going to wind up with a full loss of the forehead, cheek, and mandible regions of facial expression. Now, whether this lesion gets far enough back to hit the abducens nucleus or not, it's certainly going to hit the abducens nerve fascicles on the way out. So this sort of a medial pontine basis and tegmentum lesion will almost certainly cause a palsy of the abducens nerve, affecting the lateral rectus muscle on the same side. And if the nucleus is involved, we also might wind up with difficulty moving the other eye, since the oculomotor nerve on the contralateral side is not getting bossed around by the abducens nucleus. And if the MLF gets hit, we might also wind up with an intranuclear ophthalmoplegia. Don't sweat that. Just know that if we affect things, we're going to wind up having a problem. Now, if we move laterally and we affect these circumflex branches coming off the anterior inferior cerebellar artery, we're not going to affect those middle structures. We're going to affect, for sure, the middle cerebellar peduncle. So ataxia, for sure, cerebellar dysfunction. We're going to hit the anterolateral system and descending sympathetics. So ipsilateral Horner syndrome, contralateral loss of pain and temperature. And very likely, we're going to wind up hitting our trigeminal thalamics. So once again, ipsilateral loss of pain and temperature to the face, coupled with contralateral loss of pain and temperature to the body. And then continued involvement backwards is going to wind up getting our vestibular nuclei, so possibly nausea, dizziness, vomiting, vertigo, and we can still wind up getting our facial nerve involved if we're hitting its fascicles as they are attempting to exit the brainstem. So that can also be involved. So that's our Coddle Ponds. We'll take a look now at the Rostral Ponds and see how this same basic scheme gets applied there. Moving on up to the Rostral Ponds, we can see it looks a little bit different. So unshaded, and now we got the shaded version present here. So right here, we've got, let's start with our basics. We have our corticospinal and corticobulbar tracts. We're still in the pons, so we're going to have those same pontine nuclei scattered throughout there. And moving further posteriorly, we can see that our medial lemniscus is now kind of turned almost 90 degrees. So it's kind of laying down this way. So our medial lemniscus is right here. And it's coming closer and closer to the anterolateral system and the spinothalamic tract that's carrying contralateral pain and temperature sensations to the brain, and it's coming close to the medial lemniscus, which is carrying contralateral fine touch vibration proprioception to the brain. As before, right next to our anterolateral system, we're going to have those descending sympathetics, and we've got some kind of weird players in here now. We've got up here our medial longitudinal fasciculus, that's white matter, so let's actually shade it in. We're superior to the abducens nucleus, but inferior to the trochlear and oculomotor nuclei, so we have the MLF there. We also have our reticular formation, and it's involved in arousal and awareness, various pattern generators. We're just going to note that it's there and otherwise kind of politely ignore it. Here, on the lateral side, we have our middle cerebellar peduncle, and that's being formed by those pontine nuclei, sending their axons to the other side. But now we're getting high enough that we actually can see our superior cerebellar peduncle very dorsally here, kind of leading up towards the tegmentum that's going to form in the midbrain. Now, in addition to that, we have some sensory nuclei here. We're going to have vestibular nuclei still hanging on. They're pretty persistent. Sorry to cover my own leader line there. And just a bit lateral to them, we have our chief sensory nucleus. I'm going to draw it over here just for clarity, but the chief trigeminal sensory nucleus is up in this area of the rostral or cranial pons. And so it's over here, laterally where we'd expect a sensory structure to be. Now, just like the lower level of the pons, caudally, we have the great big basilar artery here giving off branches that go around, paramedian branches, as well as lateral circumflex branches. And just like we had the Coddle Ponds has the great big anterior inferior cerebellar artery there, the cranial pons has the SCA, superior cerebellar peduncle, running at its level. So it's basically acting like a big circumflex branch off the basilar, and it's going to be supplying blood to this lateral part of the brainstem as it goes to the cerebellum as well. Now, at this point, the Pontine lesions at this level are very similar to what we saw below. If we have these median branches get affected, we can have a hemiparesis as the corticospinal and corticobulbar are affected. If we hit enough of these pontine nuclei, we're going to have an ataxia as well. If we're hitting the medial lemniscus, we can have some contralateral loss of vibration, fine touch, and proprioception. And if we hit our reticular formation, we're going to wind up with some problems, but it's hard to really say what happens there. Reticular formation is so diffuse and there's so many nuclei scattered throughout it, it's tough to really give an exact description of what will happen. Arousal or motor patterns may be a little bit off, and if our medial longitudinal fasciculus is affected, we might have some intranuclear ophthalmoplegia. Now I just realized I left somebody out. We have over here something we haven't seen before, the lateral lemniscus, and it's conveying sensations from the cochlear nuclei towards the inferior colliculus of the midbrain. Long story short, it's taking care of sound. So if we had damage to it, we might wind up with difficulty hearing, but we're not going to be completely deaf because our cochlear nuclei are still intact. We're just hitting one of the branches coming off of it there. Now that's similar enough to the last one. What I want to pay attention to now is that the superior cerebellar artery doesn't just take care of these lateral structures. It does. It's also going to have branches that make it up here to the superior colliculus. And if that happens, we can wind up with additional causes of ataxia occurring there because our superior cerebellar peduncle is being hit as well as our middle cerebellar peduncle. And just like before, if that's getting affected, we're also going to hit those sensory nuclei there. Vestibular, likely to cause nausea, vomiting, dizziness, and if the chief sensory nucleus is affected, we're going to wind up having some problems with perception of fine touch and vibration on the ipsilateral face. So the only real difference is we've got the SCA instead of the ICA at this level. All right, we got one more level to go, so let's talk midbrain. All the way up to the midbrain. So we can see the cerebral aqueduct right here. We'll take a look now with the shaded white matter tracks in here. And there's a couple landmarks I want to point out before we go too much further. We have the cerebral aqueduct here, as I mentioned, but we've also got surrounding it the periaqueductal gray matter. So that's hanging out there. That's new. We have our superior colliculus. So we're up at the rostral midbrain if we got the superior colliculus. So we've got those landmarks right there. And now let's start with our standard. Let's look for those corticospinal axons. And they're hanging out here in the basis, or this very anterior ventral part of the midbrain. It's called the basis. And the whole thing's called the cerebellar peduncle. So we have our cerebellar peduncle slash midbrain basis here. And right up at the front, this is where we're going to have our corticospinal and cortical bulbar tracts. So the cortical bulbar will be more or less in this area. Corticospinal, a little more lateral. And medial to the cortical bulbar, we actually have some cortico-pontine axons that are going from the frontal lobe down to the pons, and from there to the cerebellum. Now, even more lateral, we have a few other cortico-pontines, but they're just coming from other places besides the frontal lobe, and you do not need to memorize that. I just find it interesting. Just dorsal to that, we've got another collection of gray matter. This is our substantia nigra, so dopamine-producing neurons present there. And another unique nucleus at this level is the red nucleus. So we've got that present here as well. So we've got a lot of unusual structures, but let's look at something we've seen before. Our medial lemniscus has come into very close contact with the anterolateral system. So here, medially, we have the fibers of our medial lemniscus conveying contralateral sensations of fine touch, lemniscus, vibration, fine touch, and proprioception from the body, and just kind of hanging off its side, posteriorly, is the anterolateral system. They're both going to the VPL nucleus of the thalamus, so it makes sense they'll come close together. But we've got a new player here because we've come up so high. Here, in close contact with them, we now have our trigeminothalamic tract, and that's going to be carrying pain and temperature sensations from the contralateral face, and running with it we have our trigeminal lemniscus, carrying fine touch, vibration, sensations from the contralateral face. So we've got all these structures hanging out here. And last and certainly not least, most important, close to the midline, we've got one of our GSE nuclei. This is our oculomotor nucleus, so cranial nerve number 3 nucleus, and close to it we've got our Edinger-Westphal nucleus. That's where we've got our preganglionic parasympathetics to the pupil and to the ciliary body, whereas cranial nerve 3, we've got the nuclei that are supplying many of the extraocular muscles, and Edinger-Westphal's axons bundle together with the oculomotor nucleus's axons, and they come out as fascicles and then leave as cranial nerve 3 right between the peduncles of the midbrain. The blood supply to the midbrain is interesting in that the basilar artery is going to divide into the 2 posterior cerebral arteries near here, and they're going to go to the medial aspect of the temporal lobe, most of the occipital lobe, and they're going to supply some of the midbrain as well. So we're just going to draw our basilar here lightly, splitting into the right and left PCA. Now what's interesting about this is the basilar gives off some arteries at its top, so top of the basilar. They're going to act very much like those paramedian branches, and some of these very medial branches of the PCA will also be covering that very medial area as we go. And as the PCA continues off to each side, it will be giving off additional branches to these more lateral and posterior structures. Maybe some involvement of the superior cerebellar artery back here, but we're not going to sweat that for now. And basically the named syndromes involving the midbrain, we have Weber's syndrome, and that's going to involve the top of the basilar artery and very proximal PCA, and we wind up just wiping out some of this area here. So what have we wiped out? We've got some of our cortico-bulbar and corticospinal tract axons possibly affected, so we might have a contralateral hemiparesis, but we also have an ipsilateral third nerve palsy. So we've wiped out every axon going to cranial nerve 3. So we've deinnervated all those muscles. We've wiped out the outputs of the Edinger-Westphal nuclei to that eye as well. So we're going to wind up having third nerve palsy, and we're going to be unable to constrict the pupil on that side. So that's Weber's syndrome. So we'll draw a little web there. Claude's syndrome is basically a very similar thing, but instead of significantly involving the peduncle, it is going to be more involved with the third nerve fascicles and the red nucleus. Now the red nucleus is a motor nucleus, but another important aspect is it receives a lot of fibers from the superior cerebellar peduncle that are coming up through the ventral part of the midbrain. So we can't really see it at this level, but the superior cerebellar peduncle goes to the red nucleus, and if we're affecting either those fibers or the red nucleus itself, we can wind up with ataxia. So a contralateral ataxia and third nerve palsy is fairly typical of what's known as Claude's syndrome. And last, we have Benedict's syndrome, which is basically both of those things put together. So we're going to have contralateral ataxia, we're going to have third nerve palsy, and we're going to have some degree of paralysis or hemiparesis, depending on the extent of the corticospinal and cortical-bulbar involvement. So that's all we have for the named syndromes. Just be aware that the posterior cerebral artery, as it's coming around, is supplying some more of these lateral structures. So a problem with it, in addition to affecting the temporal and occipital lobes, might also be causing sensory losses on the contralateral side of the body due to DCML, medial lemniscus here, and anterolateral system be affected, and trigeminal thalamic tract and trigeminal lemniscus being affected. So we'd have contralateral loss of sensation on the body and face, and it would be all sensation since we've got all those modalities affected. Involving the superior colliculus would probably cause some visual problems, but we're not going to sweat that for right now because we've covered more than enough material. I hope this has been illuminating.